young people. So there is an assumption that unmarried young people do not have intercourse, they do not have sex because they should not. And this is very clearly reflected in the attitudes of youth counselors, in the attitude of frontline providers, who not only feel that it is morally wrong for young unmarried people to engage in sex, but they actually feel it is illegal. And when you have that kind of an attitude, then the services that they provide are highly compromised. So I would like to, so obviously this results also in a lot of disrespect and abuse for women and girls coming from marginalized communities. I would like to end by saying that every girl and woman, no matter where she lives in the world, has a right to live with dignity. She has a right to voice her decisions and her choices, and these must be respected. And it is only when we have a human rights-based accountability system where duty bearers are accountable to uphold the entitlements of right holders and provide remedies. So remedies are absolutely important. In all the words that we saw describing accountability, there was no mention of either remedy or redress. I think those are critical, and unless this happens, I don't think we are going to be able to ensure that every woman and every girl gets their rights and we leave no one behind. Thank you.
Thank you. Thank you, Sandhya-ji, and particularly your last point on the importance of remedy, redress, following a rights-based approach, music to our ears. This is something that the Independent Accountability Panel gives the highest importance. Excellent. Colleagues, let us now turn to the private sector. And Mr. Poco Winches, Vice President for Nutrition and Food Systems Transformation at the Royal DSM. Mr. Winches, we appreciate the highly positive role that the private sector and food industry can play in promoting good nutrition and food security. But study after study have also documented, and we actually cited in our report on accountability of the private sector for women's, children's, adolescent health, that in the current worldwide epidemic of obesity and non-communicable diseases, the marketing of unhealthy foods and sugary drinks by large food companies bears a big responsibility for this epidemic. As someone responsible for transformation of markets and food systems to promote good nutrition, what can we learn from Royal DSM's experience to make the food industry in particular and the private sector in general more accountable for the health and nutrition of women, children, adolescents? There must be some lessons that you can share. Thank you. Please.
Thank you very much. You've set the scene and you raised the bar quite highly. How many people from the private sector are here? Okay, I feel a little bit lonely. Thank God I have a couple of friends here. Royal DSM, we're the largest vitamin producer in the world, and that means that we feel very responsible for nutrition. And we do see that today, of course, the challenge is humongous. 2 billion people are malnourished, and that's both overnutrition as well as undernutrition that plays a role. So it's a serious challenge that we face in this world today. So I agree with Kool that what can we do about this? It's a systems change. As the SDGs are not each an individual. We shouldn't look them in their individual pieces. What you heard this morning from Tis and from Joy, they went into the health side of things. But they are interacting, they are interconnected. We cannot improve health systems, we cannot improve nutrition, we cannot reach zero hunger when people don't have any money to spend. So we have to work also on reducing poverty and economic development. Otherwise, we will continuously have to pour in money to get the broken system to continue to run rather than create a healthy system. So for me, accountability is the whole cycle, the cycle of defining what needs to be done. And for me, if I say that in simple words, if we want to have mentally and physically healthy people, because they are able to contribute to healthy societies. And healthy societies are societies where we have prosperity for all, where we have social inclusion, and where we have a healthy environment in which we can live. Now, how do we look at that and how do we achieve that? Yesterday was very much around cross-sectoral approaches. The problem is too big, the challenge is too big and too interrelated to do it by ourselves. And that's why in DSM we strongly believe that it's all about complementary competencies. It is about collaboration to achieve what we have to achieve. We have to come together. We started to work with the World Food Programme because the World Food Programme 10 years ago provided calories. Well, you and I know that if you provide calories, you keep people alive, but you will not make them thrive. And the theme of this conference was survival, but then also survive, thrive, transform. And to get to that, from survive to thrive, we need to get that health and nutrition issue in there. Working with the World Food Programme, we managed to get to transform the food basket that the World Food Programme provides. And today they provide, thanks to our partnership, 39 million beneficiaries with improved nutrition, and that number is still on the rise. That's the sort of impacts that we need. That's the accountability where I am also happy with, where I'm proud to be part of that coalition that achieves that type of success. Sometimes it feels as if at the university gate, all the good people went into government and into civil society, and all the bad people went into business. I hope to be able to convince you that that is not really the case. There are also a couple of good people in business. And hopefully that number is growing after today. So what we see is we need big solutions, integrated solutions. We invested together with IFC, CDC and FMO, so development banks in Rwanda, and in a factory that produces fortified food for the first 1,000 days for pregnant and lactating women and for children. Because what we see is if we help improve the livelihood of farmers, and in our case we will be buying from 100,000 smallholder farmers, and we see now that we improve their income with 30%, that means that we get about, average family size of 5, we get about 500,000 people out of poverty. They will be able to buy better nutrition, afford better health care, and hopefully send their children to school. We create a couple of hundred jobs in Rwanda, but we buy from Uganda, Rwanda, Kenya, Tanzania. We have now, the University of Chicago did an investment study on this case. We invested $60 million, but in the period 2018-2031, University of Chicago calculated that this factory will bring $1 billion to the African continent. So that's a huge benefit, and that is calculated in improved health and nutrition status, in jobs, in prosperity that this factory creates on the African continent. We need to get that cycle changed, and that's where the accountability discussion is about. How do we change that cycle? How do we make sure that we get out of that poverty trap and thus out of that the limitations that it brings to us? What would happen if we would be able to bring humanitarian aid? Right now we import about $3 billion into the African continent in aid. What if we would stop importing that, produce it on the African continent? We spent about similar amount in Asia. What would happen if that would be bought in Asia and not imported from overseas? That would make a huge shift in economic welfare, would make a huge shift in nutrition, and would make a huge shift in health of those involved. So let's look things into the perspective of a system, and what do we need to change to get that system a much more healthy system. And I fully agree with Kool that when he said data availability and data use should never be an excuse, or the lack of data availability should never be an excuse to not act. So we act, can we improve together because we make integrated data availability and get an integrated approach on that? I think yes, there we should work closer together to make that happen. Thank you.
Thank you. Thank you, Foko. We certainly want to see the private sector more constructively engaged in promoting nutrition, and the potential is enormous, as you said. I now turn to Honorable Professor Vinod Paul, member of India's Niti Aayog, and a dear friend and former member of our Independent Accountability Panel. Vinodji, yesterday, in his eloquent opening remarks, we heard from the Right Honorable Prime Minister, Narendra Modi, India's strong commitment and high priority to women's, children's, and adolescent health and nutrition through a variety of ambitious initiatives as part of ensuring universal health care. But it is one thing to have high-level political commitment at the national level, but something else to ensure that such commitment is honored in implementation in the vast and diverse country like India. Can you please share with us what kind of accountability mechanisms have been instituted in India to ensure that local and provincial leaders and health workers truly deliver on the promises made by the nation's top political leadership? You have the floor, Vinod. 5-6 minutes.
Thank you very much. Cool. Privileged to be here on the Double Joy panel of distinguished colleagues and lead friends. Yes, as you correctly stated, my Prime Minister sets high targets. On the Independence Day speech, he said, "Lakshya bade hone chahiye." The targets have to be high. So he's a driver of change, and he has given a clarion call for a new India, in 2022, which is the 75th year of our independence. And you may have noticed that all the targets, the SDG targets, are typically placed for us to be achieved by the year 2025, if not earlier. So it is true. And this is so very important for India because we have to unlock the potential of our demographic dividend. We have 3 decades to make a mark, to be a leader in many dimensions as India. And for that, we have to be a healthy nation. Having said that, let me begin by stating some simple mechanisms that are in place. We have Registrar General of India looking at the ultimate outcomes, such as mortality outcomes. We have DHS surveys, like everybody else, which provides data on processes as well as outcomes. We also have something which is not so well known. It's called National Sample Survey Organization surveys, which typically look at care seeking, household expenditures, and out-of-pocket expenditures. So that's something which has driven us to Ayushman Bharat using the data. We also have national health accounts. We have independent studies from time to time. We have special surveys, and now for nutrition mission that the Honorable Prime Minister referred to, we didn't have a survey for a particular year, 2019, 2020, so it has been put in place so that we have annual data at the district level. We also have the HMIs, like everybody else. Do we make the best use of it? No. Do we analyze it optimally at the district level? Not sure. Does it cover all the elements optimally? No. For example, for adolescent health, I don't think we are very robust in doing so. But we will continuously improve, and we will use technology to do so. And this is everyday business for us to refine the HMIs. Let me say another dimension. We have, when we distribute resources from the government, tax collections, these are based on the needs, that's the numbers, but we are also linking it to performance. So the performance accountability is incentivized. We have a finance commission, which gives the ratio of how the central taxes are to be shared, is right now possessed with this particular task. Let me now request Sheila to just give you 3 examples in my second segment of inputs of how there are efforts to continuously improve the aspect of accountability in the system using independent data. So first one is, next slide please. Next, Sheila, just put next. So this is akin to the Uganda paradigm. We have a system at Niti Aayog. You'll see 3 organizations, 3 arms of the government playing a role in different ways. So we have a concept of state ranking on health. We've created an index that has been validated. And here we rank the states as to how they perform. But a very important aspect is not to shame, but to celebrate delta, celebrate change, how individual states make the change from where they were, because all our states are not at the same level. They have different scenarios, and what we want to reward and celebrate is the delta, and that's a buzzword that has been given. So this is one of the reports, and on the right side corner, you can see the day this report is released, there's a plethora of TV and media coverage. We are put to task, and then of course, state chief ministers and the ministers are asked. So that's one example. Moving to the next one, you heard yesterday, next one, Sheila. You heard yesterday that in order to achieve the goal of no one left behind, the government has identified 117 aspirational districts. We call them aspirational. They used to be called backward districts. These have poor indicators. They have not been performing well. So there is a clear focus on these 117 districts. This is 20% of India, the toughest part of India that is now being given a fillip, where the effort is that as a district, come to the average in the state and don't be a laggard, and then be better than that. That's the motto with which we work. And in this, the ranking of the development of the district has 3 or 4 components: health and nutrition, education, infrastructure, financial inclusion. 60% marks are health, nutrition, and education. And that's the focus, a right focus, as you would expect. Now, in order to, next one, please. Next one. Okay, this one should have come first. Again, what we do is we have 49 indicators around health and nutrition, and live ranking of these indicators as the data appears is made, and such charts are generated to show where you are. So the example of Uganda, in a way, focused on the toughest of our districts. Another example, quickly, go back one slide. Yes, this one. Now this is Ministry of Child Development, Women and Child Development, which anchors our nutrition program. And here is a dashboard on the National Nutrition Mission, which the Honorable Prime Minister launched in March. What you see here is, of course, the kind of data that you can have. That's the dashboard. You see round circles. This shows you the activities being done by various ministries, because convergence is such an important part. So we're monitoring how different ministries are playing a role. The biggest part, as you can see in one of those pie diagrams, is of course Ministry of Women and Child Development, but the blue one is the Ministry of Health. And we are watching how the blue should become bigger, that there's more converged activity. And then there's rural development, water sanitation, and so on. And also notice that since 1st September 2018 till date, till last night, we have had 422 million participants that lives have been touched. 422. This is live database, may have changed this evening. One way of showing accountability, making it obvious how we are performing, and it's available for people to see. Next one. Next one. Now, this is the last example that I wish to share with you. The health assurance mission that the Prime Minister talked about. It's Pradhan Mantri Jan Arogya Yojana, or PMJ. This is the dashboard. Next one, please. This is a page sent at 4:30 p.m. every day to the Honorable Prime Minister's office, Health Minister's office, to Niti Aayog, and to the key officials of the central government on a daily basis. Next one, what does it show? It shows in the middle column, in the last 24 hours, what our performance has been, and the cumulative performance. So we're happy to report 4:30 yesterday, 0.54 million people had benefited over the last 10 weeks under this health assurance scheme. So many hospitals, 58,000 hospitals have applied. We have made reimbursement of 70 million or 60 million US dollars. Just to say, this is the data which is being monitored on a daily basis by the Honorable Prime Minister's Office, the Honorable Health Minister's Office, and other key people. Some examples of how technology and live dashboard systems have been leveraged. Thank you, Sheila. Just to move to my last part, is that in addition to state-level reviews, state health is a state subject in India, national reviews, I may also emphasize that we have, by law, a right to information. Any citizen can ask for any information on our files. Right to information. Right to health can be mainstreamed with right to information. Our parliamentarians are very active in asking questions. And now the parliament session is on, and I can assure you that at least 2 very senior officials are busy trying to prepare replies to the questions that are being asked in the parliament. Very active. Our media is hyperbole. Very, and they're watching health all the time. That's one accountability that we go through. The Honorable Prime Minister reviews the health programs typically 8 to 12 weeks in the last year that I'm familiar with. He holds discussions with state officials, chief secretaries, and the entire bureaucracy of center. We call it Pragati. Every month, and health pops up from time to time. We have a National Health Council, and so on and so forth. And above all, in our democracy, people are watching. Today in India, thanks to the Prime Minister's work, health is central point of discussion in development. Health is a political issue for the first time, 2018. Happy to report to the International Accountability Panel that India has now brought health in the center stage of development debate. It's a political issue, it's an election issue, and the nation is accountable. The governments are responsible to be responding to the aspirations of people, and people will hold them to account. Thank you very much.
Thank you, Vinod. So good to know that these league tables are presented directly to the Prime Minister and his office, and that these are being monitored at the highest level. I think that kind of monitoring is extremely important. I recall 2-3 decades ago, I used to be with UNICEF here in India. I see some of our UNICEF colleagues here, that we used to prepare the state of India state in terms of what was happening in the indicators for children. I'm delighted that this practice is being continued and has been refined, and that now Niti Aayog prepares reports. They go directly to the top leaders, and that they are used to monitor performance and accountability. Wonderful. Colleagues, we're coming to the end. Finally, I circle back to Professor Joy Lone. I would ask you, Joy, to reflect on the presentations that our colleagues have made so far. What do you conclude in terms of how all these leaders seem to have used data for policy making and holding stakeholders accountable? And perhaps you can also share with us, what do you see as the next frontiers for data collection, monitoring, and review to enhance more effective accountability for the achievement of health-related SDGs, particularly, obviously, as they concern women, children, adolescents? You have the last word. Joy.
Thank you, Kul, for that tiny question. It's my honor to close this panel. So we have a double joy panel. We started with joy, we end with joy. I just want to scratch my name. I'm afraid I'm actually born in Uganda, and with what's going on in the UK at the moment, I may be rapidly moving back to Uganda. Do we have the data we need? Do we use the data we have? Maybe we can tie it back to the word accountability. The heart of accountability is count and ability. So to be able to practice accountability, we have to count. Some of that is quantitative, some of it is qualitative. The stories of girls and women, what has happened. But we also must have the ability to collect data that's not rubbish, and to collect data that then actually connects to people who have the power for change. So, Paul has asked me what the next frontiers are. I'm not going to give you a list of data gaps. I may be a professor of data at the London School, but I'm going to tell you that I think our biggest problem in global health, whether that's at the coalface level, where we have a healthcare professional and a woman or somebody in a family, our biggest problem is drip disease. What is drip disease? It is that we are data rich, but information poor. We live in a generation where we have more and more data. So when I started out in working in rural Kenya or working as a pediatrician in Ghana, we had to use a duplicator to produce our questionnaire. We had to put things in by hand and compute them. So we were very careful. Did we collect data that we needed? Did we use data? Now, we have massive explosion of data. But data is not the same as information. So information is when we process data. We turn it into something that actually leads to action. We take out bits that are rubbish. And we think about who we're communicating that to. So, if we think of these fantastic examples, we've heard of Joy Pumafi talking about malaria. Ambitious scale up, not enough data, they improved the data, but then they found ways to link it to heads of state. We've heard about district scorecards in Uganda, ranking, and that transition from just calling out people who don't perform to finding ways to make policymakers address systems issues for those districts. We've heard about the private sector and the need for data both within and externally to that, so that that is both accountable but also able to contribute usefully. And we've had this amazing example from my colleague and thought leader, Vinod. Whenever you come to India, you quake at the scale, but you also quake at the level of ambition. So serious, not just in policy change, but in implementing and tracking data. So how do we treat drip syndrome? How can we go forward and get rid of this disease? Well, we need to put our data on a diet. We've heard about obesity. But we need to think, am I actually getting the data I need? Not just some big heap of it. Have I got lean data? We need to get our data fit. It needs to actually work, get to where it connects to make a difference. That's using it to drive change. But we also need to look for the deficiencies in our data. So I love the statement by George Bernard Shaw. He says, you see what is and say why. I see what is not and say why not. So sometimes we only follow the data we have. And what Cool started with is, if we have a big problem, we have to make sure that the data follows that. We have to bring data onto invisible issues which are not heard or addressed in a way that they need to be. And a classic one for this may be stillbirths. 2.6 million deaths in the last 3 months of pregnancy, and almost never mentioned because we don't listen to the women who have them, or the midwives who also are traumatized when they're there with them. So we need to close gaps that are critical. We saw in the scoring earlier, adolescent health, child development. We do need to pick these gaps and close them. So I want to finish by saying count, ability, also means we have to intentionally grow the ability to collect good data, to smell bad data, because if you have garbage in, you will make the wrong decisions. We need to know how to recognize bad data and manage that and improve it. And ability. Let's cure our drip disease. Let's have Fit data that's on a diet and makes a difference. Thank you.
Thank you, Joy. And dear colleagues, this is the end of this particular panel, but hold on, we have an important another event coming right here. And by the way, right after this plenary, there are several concurrent sessions on this accountability where we can have more in-depth interactive discussion. So I would encourage all of us to go to the concurrent sessions. But right now, let me thank, and let's all give a hand of applause to our colleagues. And I request you to kindly vacate so we can have another important panelist coming for a short but very important presentation. We have, dear friends, we now have another presentation of a very important report that is being launched this morning, a brand new report on transforming the, I invite our colleagues in the present panel to, oh, you are taking a photograph. Okay, good. After the photograph. Yeah, okay. After the photograph. We come in front? Yes, please do. And then you remain here. Yeah. Where do you want us?